Okay, I think we're a couple minutes past and let people in. So, good morning, good afternoon, good evening, everyone. Thank you for being here. This is a webinar sponsored and supported by the American Public Health Association Trade and Health Forum. We have a very great lineup here of various speakers to talk to you about advancing health priorities in trade policymaking and talking about some of the challenges and opportunities. Before I turn it over to our speakers today, I just want to highlight a couple things about our forum here, and those of you who are new to the APHA Trade and Health Forum. First, just wanted to let you know that this is a forum, obviously, of the American Public Health Association, which is one of the main public health conferences here in the United States. And this Trade and Health Forum is one of the sections that's part of this forum, this association. And it's really dedicated to conducting research and increasing visibility, surrounding all kinds of issues related to trade and health. And a lot of what our speakers today are going to talk about is going to concentrate on some of the main focal points that we have here in the forum. I just want to highlight that coming up, not too far in the distant future, APHA is having their annual conference and meeting, which is held this year in Atlanta, Georgia, in the United States, November 12th through the 15th. So for those of you who are attending or presenting at this conference, we definitely invite you to come. We have our business meeting, which is going to be on Monday, November 13th in the evening. So we can kind of have maybe a happy hour and kind of fun time mingling, great for networking. And then we have two scientific sessions dedicated to various issues related to trade and health. The first is on Tuesday, November 14th, early in the morning at 8:30, standard time there, which is, mountain, that time that talks about trade, globalization, health systems, health outcomes. And then we have another scientific session Wednesday morning about trade, globalization, social policy, and determinants of health. So we definitely invite you to come. For those of you who are new to our forum, or those of you who have been around and still want to be interested in this, we also have both a Twitter account and an email. So we do encourage you to sign up here. So I'll leave this here. You can kind of copy this down, or if you want, you can email in the chat your email. And we can add you to the list. And basically, this is a way for us to kind of post different updates related to various issues regarding trade and health. And we encourage all of you, to send us updates and things that are going on around the world to, basically be involved in this area. And we also have, email lists so you can sign up there. Okay, so I am going to kick it off and send it to our speakers today. So I'm going to go ahead and stop sharing. And if I can invite each of our speakers to start. So if we can go ahead and have Belle start first. So let me go ahead and just give me just 1 second, Belle, just admitting some people into the room. All right. Okay, so let's go ahead and get started. Okay, so Dr. Belinda Townsend is a Deputy Director of the Australian Research Centre for Health Equity and a Fellow in the School of Regulation and Global Governance at the Australian National University. Bell is an interdisciplinary scholar working at the interface between public health, governance, and political economy, and her work examines the commercial and political determinants of health, particularly in the domains of trade and investment, employment, and social and welfare policy. Dr. Townsend has served as an expert witness for Australia's Parliamentary Joint Standing Committee on Trade and Health, and has presented her research on the impact of trade agreements on health to government officials participating in Asia and the Pacific regional trade agreements. So we are delighted to have her here. And her talk is going to look at public health advocacy strategies to influence policy agendas and lessons from a narrative review of success in trade policy. So Dr. Townsend, go ahead and get us started.
Thank you so much, Eric. Hopefully you can hear me okay. So I want to start by acknowledging the traditional custodians and First Nations people on whose lands we're meeting on today. For me, I'm in Canberra in Australia and I'm on Ngunnawal and Ngambri country. So I'd like to pay my respect to elders past and present. So my presentation today is based on a study that I've just published with my colleagues in the journal Globalization and Health. And it's titled Public Health Advocacy Strategies to Influence Policy Agendas. And this is an open access publication. It's with, as I said, Globalization and Health, and my colleague has just popped the link in the chat. So if you're interested to hear a bit more or to read a bit more about the study, I'm going to cover some of the very high level findings today, but I'm very happy to share that paper with you. So today I'm going to speak about the rationale for the study, the methods that we used, and then the high level findings. And I'm looking forward to discussing that, particularly in the context of Bridget and Deb's papers, presentations to follow. So to give you a bit of context for the study, we know that trade policy making can affect health in a number of ways, and that can be positively or negatively. And so my colleagues, for example, today are going to be talking about the politics of access to medicines and vaccines, and the way that trade policy making can be a barrier for timely access to generic medicines and pandemic-related policies. We know that these sectors operate very much in silos, and that there are a number of ways that commercial actors influence government trade agendas for their own interests. And that example, for example, includes their lobbying practices, as well as their privileged access to the institutional processes. Many governments have faced trade challenges to their health policies at the World Trade Organization, and that includes their health policies related to alcohol, nutrition, and tobacco. And so it's within this challenging context that my colleagues and I decided that we wanted to know what actually has worked in advancing health onto trade agendas. So we've seen specific recommendations from particular case studies, but there hasn't yet been a comprehensive analysis of what's worked to advance health across different health issues and different levels of trade policy making. And so we were seeking to address this gap. So to do this, we conducted a narrative review of peer-reviewed scholarly literature, which was a systematic search for and then thematically analysing peer-reviewed studies. And we focused on studies that we identified had studied what had led to a health issue being elevated onto a trade agenda. I think it's probably indicative that we had very broad search terms. We started with more than 18,000 abstracts. But I also think that reflects just how much commentary that there is about trade and health. But in terms of the studies that we determined, we're actually developing an evidence base and an argument for what had led to a health goal being elevated onto a trade agenda. That was much smaller, and we had 65 studies included in our review, and I think that was up until the end of 2021. Just to give you a flavour of the health issues that we've identified that have been elevated onto trade agendas, access to medicines was the most studied public health issue in our set of 65 studies, and that was followed by nutrition and food security, tobacco control, non-communicable diseases, access to knowledge, and asbestos harm. And there were a number of papers that were about public health in general. They weren't linked to a specific health issue, so we coded them as public health general, you can see here. And in the paper itself, we detail the range of outcomes that were identified in those papers. But what I can say is that many of those were small wins. So there were papers that were identifying how the outcome was that they were preventing or mitigating a trade measure in defense of a public health goal. We identified 7 categories of trade-related policy making, and they're listed on the screen from the most common to the least common, where health issues had been elevated onto the agenda. And then we also identified different levels of trade policy making, including studies that examined interactions across levels. And I'm not going to go into those in detail today, but just to note that we were looking at global trade negotiations, national policy, as well as regional and bilateral trade agreements. So this diagram is really what I want to focus your attention on in terms of presenting the high-level findings of the study. So in the center here, we have 4 common enabling conditions that were identified in many of the studies. These were favorable media attention for the health issue, leadership taken by trade and health ministers in support of the health issue, public support for the health issue, and political party support. And these were conditions that were outside the control of the policy actors that were seeking to get health onto the agenda. So we're thinking about civil society organisations, public health experts, government officials, intergovernmental organisation officials. But they were what we identified across the analysis of the papers is that these 4 conditions were commonly identified as influential for getting health onto the trade agenda. This graph illustrates those 4 conditions across the health issues in focus. So as I mentioned before, favourable media attention, that was the most commonly identified condition. That was where studies identified that mainstream media and international media taking up the health issue was influential in getting it onto the particular trade agenda and then influencing the outcome of that negotiation process or policy process. So if I can give you an example, several studies that were focused on the World Trade Organization identified favourable international media attention in support of access to medicines as key to getting that issue onto the agenda and then leading to important protections for access to medicines. The second condition, which was leadership and collaboration by trade and health ministers, or they might be called bureaucrats, that was really key for a number of different outcomes. So Peru's defence of access to medicines in its trade negotiations, Australia's leadership on tobacco control in the face of its trade disputes, Canada's trade ban on asbestos, Uruguay's defence of tobacco legislation, Ghana's food policy, and Thailand's position on access to medicines in its trade negotiations. I think the other point I wanted to make is that these conditions were often interrelated. So, for example, some of the studies identified that increased media attention was then often leading to increased public support for the health issue and increased political party support. So then what were the strategies that were used by policy actors to influence those conditions? And so we identified 6 strategies across the studies that were influential. The most common, if I start here, was using and translating multiple forms of evidence. So this is where policy actors focused on collecting evidence to elevate the health issue. And that included health evidence like health impact assessments, but also personal stories and economic evidence to support health goals. The second most common strategy was acting in coalitions. So this included coalitions between low and middle income countries, particularly in regional and global trade negotiations, between civil society organisations and between civil society organisations from different countries, but then also informal coalitions between government, civil society and experts and health experts playing a role in those coalitions. So if I can give you another example of that, low and middle income countries who acted as a bloc together in trade negotiations was found to be important in defending health goals in the Asia Pacific region, particularly around access to medicines in recent trade negotiations. The third strategy was the use of framing. And framing was important across all the types of trade policy making and particularly trade negotiations. So this is where policy actors developed and invoked different frames in order to consolidate their campaigning for health, to mobilise media attention, and to generate public support for the health issue. And civil society actors were particularly prominent in using framing to elevate health onto the agenda. And these frames included a particular access to medicines framing, human rights framing, as well as economic framing. The fourth strategy was actors leveraging other issues of public concern and using those to generate attention to the health issue in trade. So examples of this were the anthrax crisis, HIV/AIDS, SARS. One could argue COVID is an opportunity to connect a health issue that has public salience to the trade policy making agenda that perhaps is not on the radar of the public. Fifth was using different forms of legal strategy. And this was particularly identified in the studies of trade disputes and trade challenges. And it involved invoking legal and human rights, health and human rights treaties in trade policy making debates. The Framework Convention on Tobacco Control is one example, but also invoking the legal right to health in domestic law, and that's particularly within the national trade policy making studies.
So I just want to mention 2 more minutes.
Yep. And then the final sixth strategy we identified was shifting forums. And that was where policy actors maneuvered across different institutional forums to put pressure on trade-related policy domains. So if I can give you a national example of this, the Thai NGO FTA Watch, they shifted from focusing on the trade domain to the National Human Rights Commission of Thailand in order to push for a proposed human rights impact assessment of a trade agreement that was at the time being negotiated with the United States. The Human Rights Commission took up that analysis and subsequently influenced Thai law, and then human rights impact assessments of trade agreements became an entrenched feature of Thailand's trade policy making. So that's an example of how actors have used different forums other than the trade one in order to put pressure on trade policy makers. So I think summing up, what's interesting is that we've identified common strategies across different levels and types of trade policy making, as well as different health issues. And in the study, we go into more detail about the nuances of that and where there were more strategies aligned for different categories of trade policy making. But I think that they demonstrate that a range of advocacy strategies are needed to influence trade policy making. And we're hoping that these could also be potentially useful for the broader field of the commercial determinants of health when they're thinking about strategies to advance attention to health in economic policy making. So I'm almost out of time, but I just want to acknowledge my colleagues on the review, Bridget Tenney, Shani Goldman, and Deb Gleeson. And as I mentioned, this study was just published yesterday in Globalization and Health, and it's open access, and I'm very happy to share it, and I look forward to the discussion. Thank you.
Okay, great. Thanks, Belle. And just want to mention, just for the sake of time, we're going to save all of our questions to the end. So if you do have a question, please use the chat box. And Belle, I think it was shared in the chat, but the link should be there. So yeah, let's go ahead and move to our next speaker. Our next speaker is Bridget Tenney, who is a public health practitioner and researcher at the Nosal Institute for Global Health at the University of Melbourne, with a focus and expertise on HIV, hepatitis C, sexual reproductive health and rights, and access to medicines. Bridget is currently undertaking a PhD at La Trobe University that explores the impact of trade-related intellectual property policy on access to medicines in Cambodia and Thailand. And as you can see here, she is going to talk today about the potential impact of the Comprehensive and Progressive Agreement for the Trans-Pacific Partnership on Thailand's hepatitis C treatment program. So Bridget, go ahead and take it away. Thank you.
Thanks, Eric. Hopefully everyone can hear me. Thanks very much to Eric, Ginny, and Courtney from APFA for hosting us today. Very much appreciated. I'm Bridget Tenney, as Eric said, from Nosal Institute for Global Health at the University of Melbourne, but also presenting as part of a PhD candidate at La Trobe University. So before I start, I also want to acknowledge the traditional owners of the land on which I live and work. In my case, in Melbourne, it's the Boonwurrung people. and pay my respects to elders past and present, and extend that respect to any other First Nations people here today. I also want to acknowledge my co-authors on this paper, who some are here with us today: Joel Lection, Chutima Akalipan, Chalem Sak Kitty Trukil, Deb Gleeson, and also my supervisors, Deb, Joel, and Belinda. Okay, so background. So most of you will be very familiar with the next few slides that I'm going to be talking about. Maybe some of you may not, but I'm going to be talking a little bit about the rules and regulations that cover intellectual property, and I'm going to refer to intellectual property as IP. So the World Trade Organization's Agreement on Trade-Related Aspects of Intellectual Property Rights, TRIPS 1995, binds all WTO member states to minimum standards of intellectual property protection. And it obliges all member states to make patents available for pharmaceutical products or processes that meet
that people did it on his behalf.
minimum standard criteria.
That a lot of this was based on.
I think
and now this.
Yeah. It, however, contains flexibilities, and these are designed to mitigate the impact of patents. And one of those flexibilities being compulsory licensing, where a government allows the production or importation of a patented product without the consent of the patent owner. As a member of the WTO, Thailand must comply with TRIPS rules, and they have been a member since 1995. So trade agreements are also negotiated outside the WTO, and they seek to enhance trade between countries by reducing some of those barriers to trade. However, some plurilateral trade agreements, especially those that might include the EU and USA, include IP protection beyond what is required by TRIPS. And these can be known as TRIPS plus trade agreements or TRIPS plus free trade agreements, FTAs. And these can lead to longer monopoly periods and delay access to affordable generics. Excuse me. Some examples of TRIPS plus provisions include extending patent periods beyond the standard 20 years and lowering thresholds for granting patents. Excuse me. So I'm going to be talking particularly today about the Comprehensive and Progressive Agreement for Trans-Pacific Partnership, and I'm going to refer to that as the CPTPP. And that began life as the Trans-Pacific Partnership Agreement, or the TPP. And that was a proposed trade agreement between 12 countries, Pacific Rim countries: Australia, Brunei, Canada, Chile, Japan, Malaysia, Mexico, New Zealand, Peru, Singapore, Vietnam, and the United States. And as you can see, that's a very broad spectrum of countries in terms of demographics, geography, wealth, etc. This was signed in February 2016 and hadn't yet entered into force when President Donald Trump withdrew the USA as one of the first things he did as president in January 2017. So those remaining 11 countries then went on to negotiate and subsequently sign the CPTPP in March 2018. And the UK has very recently signed an accession protocol to join that agreement. So it is now back to 12 countries. The CPTPP includes most of the provisions of the TPP. However, the original TPP included various TRIPS plus provisions, IP provisions. And after the US withdrew, and in recognition that many countries might have signed on to aspects of the TPP in exchange for access to US markets, and now that they don't have that access to US markets, many of the TRIPS plus IP provisions were suspended, but they could be reintroduced if the US decided to rejoin. I know this is a very sort of busy, complex slide, but this is the list of the TRIPS plus suspended articles that are in the CPTPP. I'm just going to go through a couple of these for you because they're relevant to this study. Article 18.46 and 18.48 allow for patent term extensions, so beyond 20 years, to compensate patent owners for unreasonable delays in the patent office issue of a patent or in marketing approval for a pharmaceutical product. 18.5 allows for data exclusivity. That means that a generic company can't rely on the test data of the originator drug to register a drug. They either have to repeat the trials themselves or wait out their data exclusivity period, which in this case is 5 years. That also allows for protection for biologics, at least 8 years of effective market protection for biologics. Another one that's just quite pertinent for this study is Article 18.37, which is patentable subject matter, and this allows for secondary patenting. So patents must be made available for at least one of new uses of a known product, new methods of using a known product, or new processes of using a known product. So, for instance, if a drug is off patent, but suddenly that's found that there's a new use for that drug for a different disease process, then that can be granted a new patent. Or if there's a new method of using that medicine, it goes from a tablet to a capsule, something like that, then that can be granted a new patent. So they're the suspended articles. Not all TRIPS Plus provisions within the TPP that became the CPTPP were suspended. It still allows for patent linkage, which is in the CPTPP that is not suspended. And this is a conditional relationship between the granting of market approval for a generic medicine and the patent status of the originator medicine. The TRIPS Plus IP provisions have been shown to have increased treatment program costs, decreased coverage, increased drug prices, and restricted or delayed access to generic and biosimilar drugs. Patent term extensions studies have shown that this has led to increased government healthcare expenditure, increased drug prices and delays in drug availability, and secondary patenting has shown in studies to lead to longer monopoly periods that have delayed the market entry of cheaper generics, increased costs to taxpayers and social welfare losses. So studies around the CPTPP have explored or looked at the potential effects of the CPTPP on access to medicines and health more broadly, and they surmise that the CPTPP could increase industry influence in public health standing setting, compromise a government's ability to regulate for health and increase the cost of medicines, but no studies to our knowledge to date have quantified the potential impact of the CPTPP suspended clauses on access to medicines. So given Thailand has expressed interest repeatedly over time, going back to even 2019, expressed interest in joining the CPTPP, it's really important that we look at quantifying the impact, especially if those suspended clauses are still there and can come back upon agreement with all parties. So the aims of this particular study were to estimate the impact of the CPTPP it would have had on Thailand's 2020 hepatitis C program if it had joined the CPTPP and the suspended clauses had been reinstated. So to do that, we designed two scenarios, one being baseline, so that's Thailand's patent law and their 2020 hepatitis C treatment program, and Thailand doesn't join the CPTPP, and using that same 2020 treatment program, hepatitis C treatment program, but the suspended clauses are reinstated and Thailand does join the CPTPP. So firstly, we looked at if scenario 2 would require legislative change in Thailand, if it signed on to the CPTPP. And so we looked at IP laws and policies for compliance with patent linkage. That wasn't a suspended clause, and the suspended clauses as well. And for each scenario, we looked at the total cost of the DAAs, direct acting antivirals, which are used to treat hepatitis C. And we did this by calculating the cost of the DAA regime being used in 2020 and genotype testing where relevant, because they were using that as well, by the number of people being treated for the year 2020. And we were able to access that data from the Thai National Health Security Office, the number of people being treated and the amount they paid for medication in that year. So this is looking at what legislative change might be required if scenario 2, so if they join the CPTPP. So it's not just the Thai Patent Act, which would need to be amended due to the secondary patenting, but there's also potentially legislative change needed in the Thai Trade Secrets Act to account for biologics and data exclusivity, and patent linkage may require changes to the Drug Act. But importantly, secondary patenting would require a change to the Thai Patent Act, which would allow for secondary patenting. Okay, so the results, scenario 2 was significantly more expensive than scenario 1. So it was more than 10 times the cost of the baseline 2020 regime. And with the 2020 budget that they were using, the cost of scenario 2 would have reduced the number of people being able to access direct-acting antiviral treatment from 3,365 to 331, so a drop in treatment coverage of 91%. CP-TPP suspended clauses allow for secondary patenting, and that would cause the most immediate impact, really, in terms of the treatment program. Thailand currently has no patents on DAAs. For any DAAs, they have many patents pending at the moment, and these have been opposed by patent groups and others on the grounds that they are secondary patenting, and Thai patent law doesn't allow for secondary patenting. So there would be little or no grounds for opposition to these pending patents if these clauses were adopted.
About 2 minutes.
Thank you. Membership of the CPTPP poses potential problems for access to affordable medicines and local manufacturing. Thailand has quite an established and pharmaceutical industry, and they are able to manufacture many of these drugs. Patent linkage could pose problems down the line if suspended clauses are not reinstated, even if suspended clauses are not reinstated. Many critics argue that some of these patent barriers can be overcome by voluntary licensing, and Thailand was using a voluntary licensing in 2020 for the DAAs that they were using. However, Thailand is an upper middle income country, and so locked out of many of the voluntary licenses that have been established by the UN-backed medicines patent pool and other bilateral DAA license agreements, including originally Gilead's sofosbuvir license, and it was only included in that after Malaysia issued a compulsory license in 2017. So in conclusion, a cheaper and more viable option for Thailand, and thankfully one it has taken up since, is to use a locally produced pan-genotypic, which means it's effective across all genotypes of the hepatitis C virus, generic that it's able to make and manufacture in country. The ability to do this could be compromised if it signs on to the CPTPP and those clauses are reinstated, and it needs really to consider the impact on the price of medicines if the US does rejoin. And it has implications for not just the hepatitis C program, but all other national programs reliant on affordable generic medicines that, especially that may have pending patent application in place. Thank you.
All right, thank you very much, Bridget. That was great. So Deb, you want to go ahead and share your screen? So let's move ahead to our next speaker. So Dr. Deborah Gleason is an associate professor in the School of Psychology and Public Health at La Trobe University, where she leads the discipline of health practice and management and teaches postgraduate subjects in health policy and health law. Deborah's research focuses on public health policy, particularly at the national and international levels, and the interface between these levels. Her primary interest area is the implications of international trade agreements for public health, pharmaceutical policy, and access to medicines. Deb holds an honorary role of co-convener of the Political Economy of Health Special Interest Group of the Public Health Association of Australia. In this capacity, she plays a key role in the association's advocacy for healthy trade agreements. And her title of her presentation and what she'll be discussing is Waiving Intellectual Property Rights for Pandemic Response Products and Where to Now. This is a very controversial issue. I know that's continuing to expand. So go ahead, Deb.
Thanks very much, Eric, for the introduction and for inviting me and my colleagues to present today. Before I start, I'd like to acknowledge the traditional owners of the land on which I'm delivering this presentation, which is the Wurundjeri people of the Kulin Nation. I'm not speaking about a particular paper in the way that Belinda and Bridget have done today, but I'm drawing from work that's been done together with a number of people, including Belinda and Bridget, and also other colleagues of ours in Australia, James Scheidner and Diane Nichol. So just want to acknowledge their input to some of the material that I'll be discussing today. So the focus of my talk is on efforts to waive intellectual property rights for COVID-19 products and what happened with those efforts, which have broadly been acknowledged to have failed so far. And I'm going to look at a number of other initiatives or negotiations that are going on in the global governance space to try and move this issue forward so that we can get better things put in place for future pandemics. So I'm just going to start off touching briefly on some of the inequities in access that we saw with respect to COVID-19 products, which I'm sure you're all very familiar with. I'll talk about the TRIPS waiver proposal that was put to the WTO by India and South Africa back in October 2020, the final ministerial decision that was made by the WTO in June 2022 as a result of those negotiations, and then talk about 4 initiatives going on currently at the global level, and then think about where advocates can focus their efforts. So I'm sure you've all seen many graphs like this during the pandemic, and for me these types of graphs really highlight the stark disparities that we saw in access and still see actually in access to products for COVID-19. By November 2022, 13 billion COVID-19 vaccines had been administered around the world, but less than 25% in people in low-income countries had received a dose. So that was almost 2 years after the first vaccines had become available and were being administered around the world. With diagnostics and treatments, the disparities are potentially even worse. Of the 3 billion tests for COVID-19 that had been used by March 2022, only 0.4% of those were administered in low-income countries, and less than 70% of treatment courses were reserved by high-income countries in 2022, and only 8 low-income countries had received oral antivirals, which in many countries are now fairly routine by November 2022. So Bridget's already covered the TRIPS agreement and the barriers that presents to equitable access to pharmaceuticals. All I want to point out here, because Bridget's covered a lot of this already, is that as well as patents, the TRIPS agreement also covers other types of intellectual property protections which can be relevant in the context of pandemic countermeasures, and particularly protection of undisclosed information like trade secrets is particularly relevant here, and I'll come back to that. So to try and overcome some of these barriers, India and South Africa proposed quite a comprehensive waiver of the TRIPS agreement. Although it was a comprehensive waiver in that it would cover all health products and technologies to prevent, treat and contain COVID-19, plus the means to make those products. And although it would also cover all of the relevant intellectual property rules, it was meant to be a time-limited waiver that would simply cover COVID-19 products. So although it was seen as quite controversial, it was actually quite limited in scope. The proposal gradually got more endorsement by and support by WTO members until eventually it was supported by about 100, mainly low and middle income country WTO members, but it faced trenchant opposition from a number of wealthy countries, particularly the EU, the UK and Switzerland, also countries like Canada, Japan and Australia opposed it, at least to some degree and for some period of time. So after 20 months of protracted negotiations during which millions of people died from COVID-19, there was finally a decision reached at the WTO, which people generally don't call a waiver because really, as many commentators pointed out, it was simply a sliver of the original waiver proposal. So rather than being comprehensive, it was limited at least initially only to COVID-19 vaccines and the technologies used to make them, and to patents rather than the broader set of intellectual property rules. And rather than waiving a large number of articles of the TRIPS agreement, it only waived one clause of one article of the TRIPS agreement. So basically, all it waived was Article 31F, which was a requirement that when a developing country makes authorises the use of a patent without the authorisation of the rights holder, that use should be mainly for the supply of the domestic market. So it would ease the export of products made under compulsory licence from one developing country to another by slightly easing this rule. But other than that, it's not really a waiver. There were also a number of other downsides to the waiver. So developing countries that have the capacity to manufacture COVID-19 vaccines were encouraged to make binding commitments to opt out. And there were a number of rules within this ministerial decision that actually make it quite onerous to use. And so we haven't seen the ministerial decision in the intervening 14 months actually used to date. There was a paragraph in the ministerial decision allowing for members to decide on extending the decision to cover the production and supply of COVID-19 diagnostics and therapeutics, but the same political barriers that were there to getting a meaningful TRIPS waiver for vaccines have also prevented movement on this paragraph. So 14 months later, we still haven't seen an agreement to extend the production and supply, and it's not clear whether that will actually happen. So because of the failure to achieve, really meaningful outcome on the TRIPS waiver, a lot of advocates have now turned their attention to other things going on at the international level. And the most promising of these at the moment is the pandemic treaty being negotiated at the WHO. So this is an agreement which there was an agreement in December 2021 to establish an intergovernmental negotiating body to develop a new international legal instrument, and the aim is to have that agreement adopted at the World Health Assembly in May 2024. At the moment, it doesn't seem to be on target to meet that date. We're still in the very early stages of negotiations, and the negotiations, they're very broad-ranging and very controversial. The legal basis for the instrument is still to be determined, but the parties have agreed that it will contain both binding and non-binding elements. And after this is agreed and put to the World Health Assembly, it will still need to be ratified by member states before it would come into effect. A zero draft of the pandemic treaty includes a number of positive proposals that might assist with the equitable manufacturing and distribution of products for pandemics in the future. And very encouragingly, it did include text about time-bound waivers of intellectual property rights that could be activated during pandemics. The text is quite weak in some ways, so you can see here the wording. The parties will take appropriate measures to support time-bound waivers to the extent necessary to increase the adequacy of affordable pandemic-related products. But it was really encouraging to see that this was sort of put on the table for the negotiations. Since that time, We have seen some weakening of the language around this, and also weakening of the kind of commitment to have something in the treaty about waivers of intellectual property rights. Because of the number of controversial issues and the difficulties of moving the negotiations forward, the Bureau of the Intergovernmental Negotiating Body came up with a Bureau's draft a few months ago, which sets out a number of different options. So the original wording that you can see above there from the Zero draft is still included as an option in the Bureau's draft, but there's also some modified wording and an option to remove that altogether. So that just kind of shows you the level of disagreement and controversy about this provision, as well as many other provisions that have been put forward for this treaty. At the same time that we've got these discussions and debates happening in relation to the WHO pandemic treaty, there are also negotiations going on around proposed amendments to the international health regulations. So the international health regulations are an existing treaty overseen by the World Health Organization. Again, these amendments are being prepared for adoption by the World Health Assembly in May 2024. The situation's a little bit different with the international health regulations because it's an existing treaty. So changes that are agreed by the World Health Assembly would then automatically come into effect within 12 months for all 196 parties. And the international health regulations are legally binding. So it is quite a different instrument to the one that's being proposed for the pandemic treaty. So some...
Yeah,
2 minutes? Okay, thanks very much, Eric. So some of the proposed amendments include some text on access to health products for pandemics. There's a new Article 13A proposed for the international health regulations. The text is not as extensive in terms of what's being proposed for intellectual property, and there's no proposed text specifically on intellectual property waivers. And the focus of these negotiations seems to be mainly going in the direction of strengthening the existing commitments in the international health regulations rather than expanding the scope to cover new issues around access to products for pandemics. At the same time as we've had these two efforts going on, there's also been work done on a UN political declaration on pandemic prevention, preparedness and response in preparation for the UN high-level meeting on the 20th of September 2023. So this is coming up quite soon. But there's been a fair bit of disappointment around this process because the draft political declaration seems to be really aspirational rather than containing very much operational wording. So you can see there that there is a mention of appropriate waivers of intellectual property, but the wording overall is very much kind of pro-trade, even though it's sort of couching this reference to appropriate waivers in that context. And finally, there's also work being done on a medical countermeasures platform, which is meant to be an interim measure while these other global coordination mechanisms are being developed. So because that could take quite some time and go beyond May 2024, we obviously need something in the interim because it's quite possible we might have another pandemic quite soon, and we need to address the failings of the Access to COVID-19 Tools Accelerator, which didn't achieve equitable access in a timely way. However, there's little information available about the specifics of what's being developed for this medical countermeasures platform, and from what people who have some insight into what's happening are saying, it doesn't appear to be prepared to tackle issues related to intellectual property. It's more about distributing the products that are made for pandemics. So, so to wrap up, where do we go from here? we can't lose sight of what's happening at the WTO. So ultimately, if we're going to have waivers for intellectual property that can be activated during pandemics, they have to be negotiated at the WTO. That's the only place where we can have, you know, a legal instrument that can actually relieve states of their obligations that they've signed onto in the TRIPS agreement. Although the waiver was really disappointing in many ways, it's still possible to build on that, to expand it to cover diagnostics and treatments, to strengthen it, to look at how it can be improved to address issues like trade secrets. Although it's disappointing, you know, it's the first time that we've had a kind of broad-based waiver negotiated at all. So it is a starting point. Also, we need to look at these other global instruments for pandemics. They are important, I think, for building that normative commitment to address intellectual property barriers and to, you know, to make it a normal thing to waive intellectual property rights during public health emergencies. And so we need to make sure that that commitment is carried through and that we do have wording that will help states to build that commitment to waive intellectual property rights. Although the prospects for, you know, really meaningful text on intellectual property waivers appear slim at this point in time. As well as these global initiatives, we also need to be exploring other avenues for advancing access to products for pandemics. So we need to look at regional capacity building and collaboration. We need to look at compulsory licensing reform in countries to make sure that compulsory licensing mechanisms can actually be used in the context of pandemics in future. And I'll finish up there. Thanks very much, Eric, and sorry for going a little bit over time.
Okay, great. Renelle, well noted. Yeah, thank you, Deb. So we have about 5 or 10 minutes left. So for those of you, we want to open it up to questions, comments. So if you could go ahead and just use the raise your hand function, and that way I can just call on people and we can do this in an orderly fashion. And so, yes, if anybody has a question or comment, please just use the raise hand function, and then I can call on you. You can ask your question or comment, provide your comment to one of our panelists. Okay, Joel, I see your hand up first. So why don't you go ahead and, yeah.
So thanks for these talks. They were really insightful. I enjoyed listening to them. So my question is for Deb. So should Donald Trump become the next US president and pull the US out of the WHO, collapse the WTO, where does that leave us?
Joel, I think that leaves us with a pretty apocalyptic future in many ways, regardless of whether we have another pandemic in the near future. I think, I mean, I think that these global mechanisms aren't the be all and end all. As I mentioned on the last slide, I think that we need to be investing in efforts at the regional and national level at all to make sure that we have effective, so that we have capacity to make products that we need for pandemics in all regions of the world, not just in high income countries. And we need to make sure that, you know, that we have national mechanisms that can be activated to make those products available. We can't just rely on things that can be negotiated at the global institutions. So I think, you know, another Trump administration and the collapse of those global institutions would be, you know, devastating in a lot of ways. But you know, we do have other options that we can pursue as well.
Okay, great. Thanks, Joel, for the question, and thanks, Deb, for your response. Matteo, you have your hand raised. Yeah, Matteo, you're muted. Do you want to unmute yourself and you can?
Yeah, can you hear me?
Yes, great.
Okay.
Thank you.
No, thank you so much to all the speakers. I have 2 questions, one for Bridget and and one for Deborah. So my question for Bridget was, you mentioned some studies that were looking at the CPTPP, and you mentioned that some of the studies found that the provisions in them complicated government's access to health medicines. And I'm curious if that included the TRIPS Plus provisions that were excluded because the United States was not a part of it, or if they included them, and how, if the US were to come back to that agreement and enact the TRIPS Plus provisions, how that might complicate those dynamics. And then my question for Deborah is very naive, I'm sorry, but you mentioned that, it would, and I guess my question is, why stop there? Is there any possibility of waiving IP provisions when it comes to all health-related matters on a global scale, I should say? Thank you so much.
Great, thanks, Matteo. Yeah, Bridget, do you want to respond first?
Yeah, thanks, Matteo. The studies as a bit of a rationale background to that I put in the slides, they didn't sort of quantify, they weren't quantitative studies, they were more of a narrative of what the impacts could be and looking at health more broadly, not just access to medicine. So I can send you, actually Courtney's written one of the papers on CPTPP and when the UK joined, the impact it could have on health. So I can put that in, I'll try and find it and put in the chat, otherwise maybe I can grab your email address and send it to you, different studies, but they're basically looking at potential impacts and listing them rather than quantifying them. So one of them was access to medicines. Another one is the ability for governments to regulate for public health, and that really was things in chapters other than the IP chapter. So looking at investor-state dispute settlements, which I probably won't get into now, but it basically allows companies to sue governments for damage to their investment in a country. So if they consider that if the company has a product that is somehow damaging to health and a government tries to regulate for that, they can be sued because it's damage to their investment in a very short way. So it can really interfere with regulation around those sort of health things, and that's happened with Australia's been attempted to be sued around that with plain packaging for tobacco and things like that. So it does interfere with government's ability to regulate for public health. But yes, there weren't quantitative studies, so they didn't look at actually looking at a health economic analysis or monetary figure. It was more the potential of what it could cause and where the potential problems lie in terms of impact on health. But I can try and send you those articles if you like. Hope that answers your question.
Great. Thanks, Bridget. Deb?
Thanks, Eric. Thanks, Matteo, for the question. I think I missed the first part of it because your internet was cutting in and out a little bit. But I think you were asking, why stop there? Why just waive intellectual property rights during pandemics? I think what the negotiations over the TRIPS waiver and the disappointing outcome has really shown is that it's very, very politically difficult to get any agreement at the global level to waive anything, even in the worst pandemic in 100 years. So although I think that there's a rationale for doing that for many other products, the political realities are that it's extremely difficult to get any sort of global solidarity on this issue. Of course, we do have compulsory licensing, available under the TRIPS agreement, which countries can activate for a number of different reasons. Doesn't need to be a public health emergency. And so it's really important that we, you know, as well as arguing for intellectual property waivers during pandemics, that we also make sure that that mechanism is working to enable countries to have that that right to waive patent rights for particular products that they need to provide to their populations. And I think that's been a bit of a neglected area in recent years, and something that there's a bit of a renewed focus on now. Thanks.
Great, Deb. Okay, I think we have time for one more question or comment. If anybody else wants to ask anything of our panelists. Okay, then I will take the liberty then to maybe ask one question, and this would be for all of you. So there is a proposed trade agreement that is currently going on in the South Pacific, which is called the Indo-Pacific Economic Framework Prosperity Agreement, something of that nature. I think all of you are familiar with that. And I'm curious from all of your perspective, how the results and all the studies that you've done so far, and how does that relate to that agreement? So Belle, we could start with you, and you know, all the different advocacy strategies and how to get health on the agenda. How do you see that playing out? I think Bridget, for you, you know, there's now an overlap where you have the CPTPP and now you have this new trade agreement. Like, how would that thing, you know, look at? And then Deb, one of your last slides talked about kind of looking at the regional level and kind of, you know, making momentum. So I'd love to hear all of your thoughts on that pending agreement. So Belle, do you want to start?
Yeah, sure. I'm going to be brief because I haven't been engaging a lot with the Indo-Pacific Economic Framework because it doesn't include intellectual property. And so I sort of, in working on my various projects, I've sort of been keeping it on the sort of brief radar, but I haven't been engaging extensively with it. But what I have seen is that so I have a paper that I studied the civil society networks emerging around another trade agreement that was happening in our region called the Regional Comprehensive Economic Partnership Agreement. And I have a paper which sort of details civil society reflections of how they were able to, in some ways, break open the private or the secret negotiations to have more civil society monitoring and presentations, and that led to, or that was in part influential on why in that agreement access to medicines was sort of on the agenda, although I think it helped that the US pulled out of the CPTPP during that negotiation, and that was another sort of external factor. So I think for the IPEF, I've been glad to see that a similar civil society network has formed around that agreement, and they're having regular meetings and monitoring and analysis. So I think that the lessons of the advocacy coalitions and the framing from those previous agreements is being carried into IPEF, but I haven't been able to engage extensively to see how those strategies are happening on the ground.
Great, thank you. Yeah, Bridget?
Yeah, I'll have to echo that. I haven't been following it closely either, but I know that a lot of the advocacy that was really focused on the CPTPP has shifted somewhat to look at the IPEF as well, or the listservs I see, they're quite active on this as well. So, I mean, it has galvanised a certain advocacy movement around this, but I haven't been following it closely enough. I'm sorry to comment on it specifically and what it and its potential impact. Yeah.
Yeah, no worries. And Deb, do you have any final thoughts?
Yeah, again, I haven't been really closely following it, but my understanding is it's not a traditional trade agreement. In many ways, it's more of a kind of overarching framework. I think the thing that people are most concerned about is the e-commerce implications of it, and so I know there's a lot of advocacy going on in Australia and other countries around those aspects, but definitely something we need to have a look at more closely at some point. Thank you.
All right, great. Well, thank you all for being here a little bit after. I appreciate it. And I just want to say thank you to all of our speakers for taking the time and presenting all this valuable information. For those of you, again, thank you for being here, and yeah, take care. Thanks.
Thanks, Eric.
Thank you, Eric. Thank you for organising.